But anyway, I want to thank Jim, I want to thank Mike Reff, I want to thank your program committee for allowing me to speak today to be able to talk a little bit about the relationship we have with you all and ASCO and some of the things that we're doing at ASCO and how this relationship we have, I think, is going to turn into a really positive thing for all of our practices, and because our practices are going to benefit, all of our patients and our communities will. So let me start out today by and then I'm going to come back to this slide at the end after we talk about what ASCO is doing and how that's going to lead into what your programs are and the medically integrated dispensing. But ASCO has a vision that all patients should have access, and I emphasize the word all, to high quality, high value cancer care no matter who they are or where they live. And we know in the United States, cancer is obviously a big issue for everyone, and everybody in this country should be able to get high quality cancer care. So ASCO, in the last 2 years, has put together a 5-year strategic plan that has really been generated with the board and with our volunteers and the staff to figure out where ASCO should be going and what we should be accomplishing over the next 5-year period. And there are 4 pillars in that strategic plan. I'm only going to concentrate on one of them today, and that's increase the quality of care. And the clinical affairs department that I run now for ASCO, which is a new department, was built to be able to help practices in this environment we're in to provide quality care. And during that period of time when we got going, we somehow absorbed the entire quality program of ASCO. So we got a lot of things going on in our department. But what came out of this strategic plan in this pillar of increasing quality care were different strategies we might want to do that. And what has been very interesting is we coined a term here, and it was interesting because we went around and looked, and no other professional organization has coined this. We wanted to enhance practice health. So think about that for a second. Having run a practice for 30 years in Delaware and provided cancer care to my community in my state, if you didn't have a healthy practice, you couldn't deliver the goods. So that's a key element in this whole framework of being able to provide quality care. You have to have a healthy practice, no matter what kind of practice you are. Whether you're an independent physician-owned practice, whether you're a hospital or a healthcare-based practice, or frankly, whether you're an academic institution. I have to tell you, my academic colleagues at ASCO don't think about that very much because they're buried in all the things they're supposed to be doing as academicians, and sometimes they forget that if you don't have a successful practice, you're not providing the goods, and you need to start paying attention maybe a little bit about how your practice is run at the academic institution. So out of this came a definition of practice health. Now, how did this all happen? ASCO has an interesting program called a leadership development program. And what that is every year you have to apply, and young oncologists, somewhere between 5 and 10 years out from fellowship, can apply for this program. And 16 are chosen to go through a year-long program where they're taught leadership skills of how to be a leader. But at the same point in time, they're broken into 4 groups of 4 to work on a project. And at the end of that year, having worked as a team and worked on a project, they actually present their project to the ASCO board. And of course, we're always being asked, what project would you like, can you recommend for them? So last year, knowing that our department was kind of heading up this idea of what is practice health, it had never been defined before, that we threw that to 4 of our young oncologists. And working with our experts in our department that are really community-based folks, whether they're practice administrators or others, what came out was this definition of practice health. And I'm not going to read, first of all, I can't read the thing from here, but basically what it is practice health leads, as I pointed out earlier, to high quality care. And in the middle of it, and I think back to my practice, I don't think we ever wrote it down, we had it, but you really should have a core mission that you've identified well. Most organizations have done that. And if I had to go back to my practice now, I would make sure we wrote down what we articulated among ourselves. But anyway, that core mission leads to what we thought were going to be 4 main pillars. I'm going to tell you some of the things in them. It includes an engaged workforce within your practice, the efficient use of the resources you have, financial sustainability, and a culture of readiness. What's that mean? I'll tell you in a second what the culture of readiness is. But those 4 pillars have to be active and have to be well done to be able to reach that pinnacle at the top of providing high quality care to your community and your patients. So let me go through each one of these pillars and see what we defined in it. And let's see, I'm going to walk over here because I can't read this from all here. I got my slides here. So the quality part of it has clinical quality in it you have to have. It requires patient navigation and care coordination. It has emergency and inpatient resource support, performance measurement and improvement, financial counseling for patients, and I've put in there the medically integrated dispensing. As you've all pointed out in the work you've done, this certainly leads to high quality care. The second pillar was the engaged workforce. You have to have well-trained, skilled staff, obviously. You have to, and this is where we've put the burnout issue for physician and team burnout. And as you know, this is a huge issue. The National Academy of Medicine just put their report out, I think within the last week, on the burnout issue in medicine and how bad it is. And I know the Washington Post had a big article on it this week about how bad this is for the future of care in the United States, the whole burnout issue. And finally, and this is very important, I think sometimes we forget about in practice, it's retention and minimal employee turnover. And you have to be able to have successful recruitment. And sometimes we forget about that. If you're running your practice, you know about that, but otherwise. And that last one leads to this one, financial stability. And just think back what I just said. If you don't have a strong financial base, that thing I just told you about retaining employees and having good recruitment, just is not going to happen. But within this area, you need to continue to look at your patient referrals, the productivity, payer contracts, and again, medically integrated dispensing, well done in a practice, can lead to some level of financial stability. And finally, efficient use of, well, not finally, I got one more to go, efficient use of resources, and this is staff efficiency, is your IT and EHR utilization correct? And robust utilization of your EHR, and for those of you who are all working on it, I know how when we put our EHR in, I got it to work and I finally used it, but I really never went back to really learn, did I really use it efficiently? So, us physicians complain all the time about the EHR, and rightly so, but we're part of the issue too on that, because we never go back and really learn what are the bells and whistles that'll make our job easier. Efficient workflow and avoiding redundancy, and again, medically integrated dispensing done well is an efficient use of your resources in your practice. So finally, the culture of readiness. Now, what are we getting ready for? What we're getting ready for is being able to provide good care and literally do well in a value-based healthcare system. Even though it's taken a while to get there, it's clear that those who are the payers of this world, including the self-insured employers, are looking at a value-based healthcare system, and we're gradually trying to shift over to that, even though it's clunky getting there, away from fee-for-service and volume-based payments. So you need to have effective governance, you need regulatory preparedness, you need an engagement with your payers, you need community engagement, and again, a medically integrated dispensing unit within a practice is going to help you as you move into this value-based healthcare system. So ASCO is committed to practice health, and if you ever have a chance here, and again, I'll tell you how I see it, the ASCO website is pretty hard to use, and I've been dealing with that for decades as a physician. So I convinced ASCO that in our department with clinical affairs, we really wanted to get a website that worked, that was dedicated to the practicing oncologists and team out there. So we do have one called Practice Central. So if you have a chance, go to practice.asco.org, and you'll see all kinds of things on there about how we can help practices. And practice health, as we get this better defined and figured out, we'll move on to that. So what are the types of things in clinical affairs we're doing right now to be able to help this area? So one of the things we started is a consulting group, and we have two major areas of consultation we do. One is in practice operations, which is, you can see it's kind of a smorgasbord. You can pick and choose if you have gaps you need to fill, what you would like us to help you with. But practice operational assessment, that readiness assessment, we have a readiness assessment tool that a practice can look at and say, am I ready to get into a value-based healthcare system and contract, and where are my gaps I need to fill? We have customized consulting, and we do analytic services, and that's one of the things I've grown at ASCO, is in today's world of value-based medicine, the amount of data that's going to start flowing to you, and this has certainly been seen in the oncology care model, is enormous, and you've got to be able to figure out how best to look at that data, how to analyze it, and then how to use it so you can be successful in this system, particularly when we're being asked to take two-sided risk with the payers. We also have clinical care delivery, and you can see all the things on there. We have an assessment of your clinical care delivery system, and we actually don't do nurse training. We partner with the Oncology Nursing Society to do that, but we point people in the right direction on that. And you can see all the other things we have on that. The other thing that we've designed at ASCO is this program called PracticeNet. And what PracticeNet is, and I use it, we'll talk about it when we get there. I think most of you are familiar with the COPI system, the Quality Oncology Practice Initiative, which is ASCO's system to measure your quality of care with different measures. This is kind of the equivalent of that care quality on the business side of the practice. So what we do is the practices we have, we actually hook directly into their practice management systems and pull out information about how their practice is performing in terms of the financial end of it and others. And we have then surveys we do to supplement what we can get electronically in terms of staffing, salaries, and things like that. And what we're able to do, and we're about ready to start publishing this year now that we have enough practices that it's kind of de-identified, is benchmarking for practices of all different types. We have all different types of this. And I'm hoping to grow this to several hundred practices. We have, what does it say there? Well, we're up to 52 in it right now, and I have another 14 onboarding right now. And part of the reason, if you look down in that left-hand corner, it used to be a program that you needed to pay per NPI to be in it, but I convinced the ASCO leadership this should become a member benefit. So if you have one ASCO member in your practice, you can join this at no cost. And the practices get quarterly reports, and you can see the types of practices we have in there. We have medical oncology, we have radiation oncology data now, and we have 10 practices, actually 12 now in the oncology care model we have data. And there are big data sets we have down there, and the one I want to point out is the one between 9 and 12 o'clock there, which is the Chronic Conditions Warehouse. And that's an interesting data set I never knew existed before, but that's the data that Medicare gives the oncology care model practices. And what it is, it's a complete data set on total cost of care at the patient level. So you can really begin to evaluate things. And that's one of the things we've done this year is we've developed our system where we can take that type of PHI, personal health information, and do it securely. Because the practices, we started giving them benchmarks, say, well, I need more detail. Where am I having issues, at what level, and what kind of patient issues? So there's all kinds of data we get there through this system. And these are the type of reports that you see come out of it. There are provider breakdowns in terms of per provider, how you code, how you bill, and all that. There are practice trends. There are peer benchmarks that we're forming right now that you'll see published this year in the JOP, in 2021 in the JOP. And what's really important for ASCO is this database allows us to do policy and advocacy. So how does that work? Anytime that CMS, for instance, comes out with a new payment schedule in the oncology field, we can immediately go to this database and model exactly what it's going to do per practice. And I can tell you where I know it made a difference. If you know, back a couple years ago, CMS was going to do this Part B demonstration project where they were going to pay for drugs differently, and they had it all figured out at the big macro levels that it wasn't going to affect practices. We immediately modeled this on about 12 PracticeNet practices and showed how it was going to have a really negative effect on the practice revenue and cause all kinds of trouble. And I think that real data helped postpone that program. As this program grows, we can model. So I can tell you we did in the last year. You know, they said they're going to collapse all the E&M codes from 2 to 5 into 1. We were able to model immediately on oncology practices how that would affect them. And that data makes a difference when you go to Capitol Hill to talk to the legislators, or you go to CMS to talk to them about the rules they're making. And again, I know our academic colleagues try to figure that out with the macro numbers, but we have the real world data. So this is really a great program that helps everybody. Now, here's a works in progress, and I'm going to start the Oncology Medical Home. And I want to start at the top there because we're working with the Community Oncology Alliance, COA, on this. And I think this is another example of why I'm here with you all at ASCO-NCODA, that at ASCO, we want to partner and work with our colleagues in the area where they have expertise. So this is in progress right now. And what we're doing is we're taking the program I'm going to tell you a little bit about in a second, COPI certification, and adding that to the work that COA has done over the year to come up with an oncology medical home certification program. And you can see all the elements that are in that, and certainly the practice dispensing will become a part of this. So, pay attention, because this hopefully will be rolling out next year as we get this all figured out and get it ready to go. But that's another big project we're doing. Again, this is all coming back to make the practices stronger and to be able to allow them to deal with this changing value-based healthcare system. So if you have questions, we have two folks that are practice engagement folks, Chris Lobiondo and Ann Chapman. And Ann is actually here and at the ASCO booth in your section over there where we have all our information. And if you want to, stop by Ann, and she can give you much more details on any of these programs and other ones I didn't even tell you about. So please stop by and see Ann. She's wonderful to talk to, and in the exhibit area you can find her. Okay. What about quality and what we're doing with that, and then how's that going to feed back to what we're doing with you all? So if you start out on the right-hand side of the slide there, ASCO's quality begins at the top there with guideline development. So ASCO puts out high-quality guidelines, and it's quite an extensive process of a total literature review with experts in the field coming together to be able to then say, these are the guidelines, and they change over time. Pay attention to that, because we're going to come back to that in terms of the medical dispensing. So that from guidelines, then ASCO has a group that actually makes quality metrics. And this has been a whole new world for me to learn about. I got to tell you, developing a measure of quality is a major feat, and it's expensive. If you want to do a process measure, the testing and the validation of that you have to do costs about $40,000 to $50,000, and an outcome measure can cost up to $1 million to build. So these things are just not, let's write down and do this. You've got to figure out, in the new world now, the electronic health records in particular, how you're going to get that data. You need to test it, and then you need to validate it, and it's an expensive process. So ASCO has a measures library where these measures go into. We think we have about 175 measures, which are way too many. We're going to be cutting those out because we're all into process measures, and they need to go away. But from that library, the COPI system, the Quality Oncology Practice Initiative, takes its measures and then deploys them in your practice. Now, the COPI system has been around now for about 14 years, and it's really set up to be a self-assessment system, where you put your data in, and we've built benchmarks for quality metrics, and you compare yourself to the benchmark, and if you theoretically, if you see have a deficiency, that gives you a target to do practice improvement on. The COPI system to date has been a manual abstracted system where you sample a certain number of charts. And it has a whole bunch of different modules in it that I'm not going to go into, but there are disease-specific modules, there's palliative care modules, there's end-of-life modules. All these different modules are in there. And there's a number of measures per module that you do. But out of that comes several things. First of all, if you go down to it's about 5 o'clock there, we have a quality training program that's been up and running for 5 years. And this is where practices can bring a group to a training session where you learn Lean and Six Sigma technique and actually work on a quality improvement project for your practice. And what you do is you learn to do quality improvement. So that team can go back to the practice and do it over and over and over again. We have the COPI reporting registry, and this is our first foray into electronic measure of capture. In the MIPS, what it is a qualified clinical data registry. And what that is CMS will deem certain professional associations or other registries capable of reporting your MIPS quality measures in the quality payment program. And because of the quality payment program, the percentage of charts of all payers, not only just Medicare, have to be reported on. It's not a sample. It started at 50%. I think this year it's up to 70%. So to really do this well, you have to electronically capture this. So we've had this up. We're in our 3rd year now of we have about a 25 measure set. You only have to report on 6, where we extract from your electronic health record, and you don't have to do any manual abstraction and can do your reporting. So this is our first foray into electronic measure capture, which is what the COPI system has to eventually get to. We can't keep doing this manual abstraction. COPI is now international. We have practices around the globe putting data into it. And we have teams doing quality training from outside of the United States coming to the US, and we're actually doing quality training programs in countries around the world. And that gets me back, and I'll go back now to 1 o'clock, the COPI certification, because that's where the ASCO-NCODA project is landing. About 7 years into the COPI program, practices that were getting high COPI scores came back to ASCO and said, is there some way you can recognize us as being a high quality practice? So the COPI certification program came around. I'm going to show you the details of that. But basically what it does, it says if you can prove to us that you do high quality care on your quality scores, we're going to move to a new dimension, and that's going to be chemotherapy safety. Do you deliver in your infusion centers, and I like to use the word day hospital because that's really what they are, safe chemotherapy for patient safety and high quality? So let me show you how that's worked out, the certification program. It's a 3-year certification a practice gets, and right now there's over 300 practices in the United States that are certified, and we now have certified practices internationally. I think we're up to about 16, and the vast majority of them right now are in Spain and Brazil, and I can tell you later why those 2 countries have taken off, but they have. But we have, and this is something, ASCO hasn't gone out trying to sell to people. We've had practices outside of the United States saying we want to be certified just like American practices. So this program has grown and continues to grow. And the way you get into this, as I pointed out, there's a 24-measure pathway from COPI that you have to put your data in from different parts of those modules. And if you get a high enough score, then you get in and can apply for the program. And this is done, as I said, through chart extraction and and we now can do that module through the ASCO's electronic platform, the CancerLink program. So if you're a CancerLink practice, you can do this electronically now. Once the COPI score has been achieved, the practice is required to then go to the chemotherapy safety standards. And once you have your standards in place, the practice undergoes an on-site survey with a peer-reviewed select team of oncology professionals, and this is a big deal. I ran the NCI clinical trials program in Delaware for 10 to 15 years, and I had an NCI cooperative group auditor in there. It seemed like every 3 months, but we did a lot of trials. And I got to tell you, my nurses in my practice said when the ASCO team came, it was just as stringent of an audit as we got from the NCI clinical trials programs. Usually this process, once you've gotten your score, takes anywhere from 6 to 9 months because we have to schedule the audit team. We review the standard operating procedures before the audit team comes to make sure they're in place, and then the audit team comes. And you have to do this every 3 years, and in your in-between years, you do have to participate by putting data into the COPI system. The standards of chemotherapy, there are 4 domains that lead to different standards and elements. And there are 28 total standards that cover your policy, your process, and patient documentation. There is a standards manual you could look at right online with the online there. And I'm just going to quickly review what are the 4 domains for chemotherapy safety we have. There's creating a safe environment for staffing and general policy, and that defines the qualifications of your staff, chart documentation requirements, and relevant patient resources and policies for patient documentation and follow-up. The second domain is treatment planning, patient consent, and education, and it defines requirements for consent and education process prior to a patient beginning their treatment. The third domain is ordering, preparing, and dispensing and administering the chemotherapy, and this has requirements for chemotherapy order sets, the order verification, the labeling and safe handling, and the extravasation management procedures that a practice needs to have in place. And then domain 4 is monitoring after chemotherapy is given, including adherence, toxicity, and complications. So to earn the certification, as I said, you have to get your score. You have to adopt and demonstrate the policies and procedures that we've established. And then you have to undergo an on-site survey and peer review by a select team of oncology professionals every 3 years. Now, this chemotherapy safety was not just built by ASCO. It was done in conjunction with the Oncology Nursing Society, and we have published the chemotherapy standards and updated them periodically. I think the last update was 2 years ago where we actually expanded it to pediatric chemotherapy safety. All right. So what about this on-site survey? Well, you observe the patients. You actually come in and see things. This is not check the box, get your certification. You got to show what you're doing and that you're actually following them. So at least 2 patients in the chemotherapy suite will be selected for observation. And ideally, these are not somebody starting their first cycle, but are somewhere into the treatment. And of course, as always, the patients have to say, yeah, it's okay to have the ASCO auditor observer there. Oral chemotherapy patients will be selected, and that's really done separately and reviewed by really a chart review and not actually with the patient. And what the auditors actually observe are chemotherapy orders, preparation of the chemotherapy, administration of the chemotherapy, and post-chemotherapy handling, including the discharge instructions to the patient. So what do you get out of COPE certification? And some people would argue maybe not enough yet, because that's one of the things we're working on, is to get more and more value into this thing. Obviously, practice improvement, a demonstration of quality. And I have to tell you, when I ran my practice, if you had to, as I said, what keeps you awake at nighttime, I always felt our biggest liability in terms of getting into trouble in medical malpractice was in the chemotherapy suite. An error there would be devastating, as we've seen, you know, in the press periodically over the years. And then again, we looked at this program as at least doing something that we thought would at least have us feel a little better that we were meeting standards to minimize errors and minimize problems. But improve efficiency, effectiveness, some public trust, and maybe a competitive edge in your marketplace if other people didn't have this. We went out here and as the medical liability issue, we showed this to one of the largest medical malpractice companies in the country, and they were so impressed. They said, anybody that's COPE certified, you get a 10% automatic discount on your medical liability insurance. If you have your physicians, obviously, if they're board certified, they need maintenance of certification. They get points. The American Board of Internal Medicine looks at this program as something that's valuable and gives points for being in it. And there are CME and CNE credits you can get for being in this program. And there are payers in the United States that have recognized this and improved payment in practices. I know there was a big program in Michigan at one point in time. I think that's scaled back a little bit, where the payer, Blue Cross Blue Shield of Michigan, identified practices were COPE certified. And I've never gotten the details. I think Blue Cross Blue Shield of Illinois does something also for this certification. So what's this all lead up to? This leads up to why I'm here, and having told you about the things we do at ASCO and what we're trying to do, how does this fit into what you've all created here? And that gets into the medically integrated dispensing. So how did this collaboration come about with you all? Well, in November 2017, we had one of our certified practices notify us that Express Scripts had recognized the COPE certification status that allowed them to become a specialty pharmacy with accreditation. And we're going, that's of interest. We hadn't really thought about that or heard about that. So in further discussions with them, they said, you need to talk to this guy. His name's Mike Reff. So Mike enters the scene and things began to happen. So what happened in 2018 is we got together and said, okay, what have you all at NCODA figured out on this? And what have we done in COPE certification that at least brought this to the attention for one practice to get accredited? And what we did is we compared the standards we had developed and tried to figure out where did we coincide with each other and where were things that NCODA had developed that we really hadn't thought about because we didn't have the expertise that you all had. So during the year of 2018, with Mike and others in your group and with our COPE certification staff, we began to formulate, could we have a combined set of standards that would meet the needs of practices? And remember, I showed you on that first slide on quality at ASCO, quality begins up on that right-hand top where we do guidelines. And as I said, we have a very strict and rigorous process to develop guidelines. So the decision was made, and I think properly, that the work that was done by the two groups should actually go through that rigorous evaluation. So we put it into the guidelines department, and members of your group, members of ASCO, as experts came together with our guidelines staff experts, and over the course of the first half of 2019 did the literature reviews, did everything else, and actually came up with a formal guideline for oral dispensing in the office. And with that, that was taken to our board of directors in August of 2019, and the ASCO board of directors approved the medically integrated dispensing for chemotherapy drugs and that are being defined as the ASCO-NCODA standards. Now, where is that right now? And Mike Reff has more information than I have on this. This will be published in the Journal of Oncology Practice. And again, as I've learned over the years, you really need to have this thing published so other people can begin to cite it. So it's on the way. Mike said he just got a query back that it's close to being published. I keep looking at every JOP that comes out and saying, was it in there finally? So keep your eye out. Somewhere in the near future, you'll see the ASCO-NCODA standards actually published. And like I said, I put fourth quarter there. Well, we're in the fourth quarter, maybe the first quarter of 2020. I have no control over when the journal does what it's going to do, but I think it's close to publication right now. All right. So what's next once these standards by our groups get published? Well, what we hope to do is move this into the COPE certification program. And I put a term there, we really isn't the name yet, but I put COPE Certification Plus. So what's our vision on this? That the medically integrated dispensing standards and elements will be an optional add-on to our usual COPE certification. So practices that want to be in medically integrated dispensing will have the option to add this on to COPE certification, and that hopefully that certification then can be of help in working with PBMs and payers. So we want to expand the current COPE certification standards that already do include patient and family education, oral adherence and toxicity monitoring, and patient documentation. And then the new standards that you've all brought to the table here need to be figured out and added into this process that includes patient access to an MID staff, dispensing and refills, benefits investigation, medication disposal, and adverse drug reaction tracking. So these are the things we don't have in COPE certification right now that have to be brought into the program in some way. And then, as always, we're not going to just check the box. This will become part of the on-site survey. And what we would expect the auditors to observe would be patient documentation, drug storage and safe handling, initial and refill processes, and potential use of waste tracking. Now, again, I'm a little bit familiar with that because in the NCI programs or with the cooperative groups, you had to keep all that stuff, and that was part of your NCI review, was how your pharmacy was responding to a lot of these issues here. So one of the things we do, and I think I've pointed it out with all these programs, is we like people to take advantage of what other organizations have developed as tools to help them to actually improve their care and to close gaps in what they're trying to do. And I've put on the list here, actually provided by you all, these are many of the resources you have to help practices in this area of medical and integrated dispensing. And certainly as this thing gets built out properly, these will be resources that practices can choose to use if they desire. And what we do, how this actually works is, as an accreditation organization, we can't mandate legally that somebody does this or that, but we make available to them, if you have a gap, here are resources we know to go to use those. So these will be very important for practices, and certainly we'll make sure they're aware of them as we go down this road. So where are we now and what's the next step? Well, once we get these standards published, hopefully very soon, what we need to do is we need to take those standards and turn them into a certification standards program. And then what we would like to do as we develop that is survey our COPE certified practices and NCODA practices, many of them are the same, to gauge their interest if this type of additional certification would be beneficial for them. And then we need to solicit then pilot practices in 2020 to begin this, to see if this program as we design it actually works and where we need to tweak it once we get it going. And then I'm hoping that we'll have a formal launch of this program later in 2020. And if you told me this could be launched at ASCO's behemoth, annual meeting with 42,000 people there, that would be nice. I don't know if we're going to meet that timeline, but I've kind of set that stage that working with you all at NCODA, if we could get a lot of this done by then and have this launched, that would be wonderful. So I come back to where we started this talk about what is our vision, and I think it's everybody in this room's vision that all patients should have access to high quality, high value cancer care, no matter who they are and where they live. So I want to just check the boxes here. How do we turn this vision into reality? And we think there are really 4 fundamental challenges on this. The first one is access. We need to be sure that we're expanding patient access to affordable cancer care and clinical trials. And I've put there, I think the medically integrated dispensing program fits that need. It does expand access to important drugs in the oncology field that are just expanding every day of the week with a new drug coming out. Challenge is delivery, transforming cancer care delivery and reimbursement. And again, I think the medically integrated dispensing unit will help us as we develop these new reimbursement systems and try to hold down the cost of care and the wastage of drugs and things like that that you've all pointed out happen. What about quality? We need to make sure we have implementation of consistent evidence-based quality standards. And again, with the medically integrated dispensing program that we've worked on together, I think we are defining what the quality is there that everybody should have in this arena. And finally, research. And I bring this up because I think this program, working with you, provides an opportunity. You've already begun to do some levels of research on drug wastage and things like that. I think if we get this program going with a lot of folks that are involved with this model, we'll be able to begin to ask really good research questions on what is happening in the dispensing realm and what is happening with patients that get all these oral drugs. So that's where we are today, and I have to say, you know, having you all at ASCO-NCODA come with us at ASCO has certainly opened our eyes to new things we didn't know about, and an expertise that you've all been able to bring as pharmacists has been just absolutely wonderful. And I think this collaboration is going someplace that's very important, and I think we're very excited about it. So I'm open for questions that you might have at this time, and I think, do I see any ones that are sent in electronically on the board here? And we have microphones too, so either electronically hit me or verbally abuse me.
If you have any questions, please there's 2 microphones here, probably some over there. And again, use your app to put in questions. If you're shy and don't want to come up and talk, that's okay too. Here we go.
You had mentioned about the medical home, and I was wondering if now that Fred Schnell, part of COA, is engaged with the Commission on Cancer, is there any
Yeah, so that's a good story. COA and Barbara McEnany in New Mexico, our just past AMA president, had put together an oncology medical home certification program, and actually with the Commission on Cancer, and this was maybe 4 years ago now, went to the Commission on Cancer to become the accrediting body, and for reasons not completely clear to me, it didn't work out. Right? So the thing kind of got off the ground, but then didn't go anywhere. So our COA colleagues and Barbara approached ASCO knowing we had a lot of tools in place, which included on-site audits and quality data collection and things like that, to say, could we team up in some way to actually bring this to fruition in a different way? And that's what we've been working on. And as far as I know, the Commission on Cancer is not part of the equation at this point in time, and we're moving with COA and ASCO together to do this. Yep. So you'll hear more about that, hopefully, as we get into 2020.
There are some questions there.
Oh, here we go. We got questions in front of me. Okay. As practices are shepherding the total cost of care through innovative programs such as the Oncology Medical Home and the QCP Plus, how helpful are some of the ASCO-NCODA tools suggested in the patient-centered standards for medically integrated dispensing and the ASCO-NCODA standards? Well, I think the answer on that is in any of these value-based systems, we are going to be responsible for some level of total cost of care. We have our own oncology alternative payment model that was published in 2015 that we're refreshing right now. And what we're doing in that one is we are going to take some skin of the game, particularly on supportive drugs, and we're going to try to get us out of the equation on total cost of care on oncolytics by saying pathway compliance takes care of that. We can't be responsible for the launch price of drugs, and if it's the right drug and it's expensive, patients should get it. But we should be responsible for using the drugs for the right patient in the right situation at the right time. So to get back to the question there, I think as we develop these standards and prove that we can efficiently use expensive drugs, that will have a big role to play in the APMs, the alternative payment models. And even though we concentrate on quality, and appropriately so, I have to tell you, the payers concentrate a little bit on it, but they really concentrate on the cost part of it. And I think by properly having dispensing units, properly following guidelines and pathway systems, that's where we'll have a benefit. And I can tell you, I've said this to every payer out there, we're not going to drop the cost of oncology care. Perhaps we can mitigate the rise of it a little bit by properly doing what we need to do. So I think this will fit into the future roles of the alternative payment models and the value-based systems. Let's see, second question, with a variety of roles supporting physicians, how can ASCO-NCODA further support the certification and the ASCO-NCODA medically integrated? So I think as this thing rolls out, again, we're right at the very beginning now of how we're going to design this, and I think you all have been very important in establishing these standards, and I would view you all as being folks that will be colleagues of ours helping us in the certification program, such as auditors. We need more auditors to come in to do this, and also promoting the program with your practices and helping us promote it to payers and PBMs. So I think there's a key role that you all are going to continue to play in this, and we want you to play a key role in it. What are ASCO's priorities and how can ASCO-NCODA contribute to them? Well, I think I kind of presented to you where we'd like to go in terms of improving quality of care and access to everybody. And again, I think what I just said as colleagues of ours working with us together on this, making sure if they were going to roll this out, that it gets rolled out across a lot of different venues with a lot of different people, and convince those in the payer world that this is a value that they need to pay attention to. And what are, let's see, I think that's, do we have another one?
ASCO priorities.
How do you define an MID? Well, I define it the way you guys define it, because that's my area of, not area of expertise. And I think the medically integrated dispensing unit is a key component in a practice that's integrated with the total team that's taking care of the patient. And that's my level of knowledge, and you all have helped us define that through the standards that have been made.
Oh.
Obviously, the basic, the major cost of operation for us is the cost of drugs. And while we can bang the quality drum all day long, and that's what we do anyway, no matter if you're an OCM or MIPS or COPE certified, the patient's at the center of all we do. But we can do very little about the cost of drugs or the total cost of health care, and the total cost of health care continues to rise. That money's not coming back to the practice. It's going somewhere, and somewhere between the payer, PBM, SP cabals is where it is. And the ASCO-NCODA ASCO partnership is wonderful. It's spot on, and it was a long time coming, and thank Mike and you for making that finally happen. Where's ASCO stand on the vertical integration of these payers and PBMs and SPs that are very opaque and harboring the bulk of this money?
So I think that gets back to the question about the advocacy and policy on the PBM issue. But to get to your first point is, in this healthcare system, we do have some control over some of the costs. And that's what we've purported that us as oncologists and the entire care team need to be responsible for, and we also need to be benefited when we do that properly. So where do we control those costs? As I said, standardization of care, so the right patient's getting the right drug. Where we have options on lower cost equivalent drugs, using those. And the other area is having your practice set up in a proper way, like an oncology medical home, that minimizes emergency room use, that leads to hospitalization, and better end-of-life care. And I can tell you as an oncologist, you know, how many times we get the fourth and fifth line therapy that has a minimal benefit to anybody, and that's a tough discussion to have, but those are the things we have to start doing. In a properly designed value-based healthcare system, when we take the risk for the things we control, we should then get the benefit financially when we control it well. And that's why I just pointed out here in the oncology care model, the practices are responsible for total cost of care. And as the price of the new drugs go up and up and up and up, it looks bad. Our model that we're going to put out here says pathway compliance takes us out of that equation in terms of whatever that new drug's going to cost, if it's the right thing to use. But where we will take some risk is when we have equivalent drugs, and that usually right now is mostly in the supportive drug space. but it could lead to other ones. So again, I think the answer for us out there is yes, transparency needs to come into the system. We need to see where money's disappearing and try to get it back into the system, and then we need to be reimbursed appropriately for the part of the system that we control and manage and make sure it works as efficiently as possible.
Those aren't yours. Any more questions? Anyone? Thank you, Dr.
Well, thank you. This has been great, and you all have been great help to us.